So just to take you through the current guidelines, and I think this is important, is that currently treatment is recommended for all people under the US guidelines who have a count of 500 or below. It's considered absolutely essential for people with 350 CD4s or below. Now there's division about above 500. They have a large scientific committee of eminent scientists, and once they actually went to a vote and it came out 50-50. 50% said, well, we think everyone above 500 should be started on treatment, and the other 50 said, well, we don't think we can go that far. We think it should be on a case-by-case basis, evaluating the whole picture. So at this point, expert opinion on when to start, and particularly when to start at a higher count above 500 is divided, but it's favouring early treatment. Now, I mentioned at the beginning the CROI meeting, which is happening in March. I think that will really change quite a number of things in the US guidelines. I think it's going to be more clear-cut. That's simply a prediction on my part. But these guidelines have not been updated in any substantial way for well over a year, and there have been a couple of really important studies that have come out since then, and they will no doubt be reflected in these guidelines. So it's an evolving picture. So I want to now highlight 3 of these groundbreaking studies which have emerged around the time of the 2011 declaration, and actually before the US guidelines had come out. And the first one is the HPTN 052 study, and this study a very large study, looked at transmission of HIV among 1,700 discordant couples in Africa, North and South America and Asia. That is, couples where one part is positive, the other negative. And so the couples were randomised into 2 arms. Arm 1 was to start treatment immediately, the positive person to start treatment immediately. And the other arm was to be monitored, not go on treatment until CD4 of 250 was reached. Now, couples were given extensive counselling, they were provided with condoms, and they were provided with primary health care. So they're not just taking treatment in isolation. And the findings are pretty significant. Transmission was reduced by 96% in serodiscordant couples where the positive partner was on treatment. So in this very large study, there were 39 transmission events. 4 of these occurred in the arm where people went on treatment immediately, and 35 occurred in the delayed arm. So that's a pretty stark finding, pretty clear cut in favour of the benefit in terms of transmission to your partner if you're on treatment. In this study, if you were on the treatment. Now, I do remind you that this is a study looking at heterosexual couples only. It's not looking at homosexual couples. So just summing up a bit more of the study, 96% reduction in new infections. Also, for those on treatment, 41% reduction in disease progression and death compared to those who are on the observed arm. Interestingly, and it's not quite understood why, there was an 80% reduction in TB. Now that's obviously taking into account the number of countries in this talk have high rates of TB. I think we must apologise to our colleagues in Switzerland, because the Swiss statement, which came out some years ago, said exactly what this finding has reinforced. So the Swiss statement was right. This study should immediately inform our clinical management for heterosexual couples, and we have those in Australia, so the message needs to be got out there about this study. MSM couples, well, I don't think you can really just say, well, this doesn't apply. I think it does, and many clinicians will argue that it does apply. Does it apply to the same degree? We don't really know. But I think it's very probable that there are great similarities between the findings of the two studies. And indeed, if you sort of extrapolate the findings of these other studies, which I'm going to show you later on, I think it adds to that case. Will we ever do a trial like this in gay men? No, I don't believe you will. It would be completely unethical, and that would be crazy to participate in it. So, I guess I can't really say too strongly how important this study is, and Science, which is one of the leading medical journals in the world, has hailed the 052 study as the breakthrough of the year. And I'll just read a couple of bits from it because I think it's important. We've long debated whether treatments used to treat people actually have a double benefit and cut transmission rates. There was understandable scepticism, but as I mentioned before, this study found a 96% reduction. And the conclusion of Science magazine in awarding this breakthrough of the year, scientific breakthrough of the year, was that it has profound implications for the future response to the AIDS epidemic. And I think that's true. It is a really, really important study. And the fact that it's randomised, really well conducted, carries a lot of scientific validity. So another study that's just come out in December is the Setpoint study. Again, it's not referred to in my paper, but it will be when I update it. And this has sort of given us some more information on the eternal question of how early is early treatment, when exactly should you start? I'm talking really about above 500, exactly when you should start. And I just remind you that there's another study going on called the START study, which has, I think, from memory, 4,000 participants. Australia's looking at it as a participant in it as well. And this study is looking to answer this question, how early is early? So what the Setpoint study did was to look at disease progression very early after people became infected, during the first 6 months. It didn't actually look at them during seroconversion, but it looked at them in the 6 months following diagnosis. So it did capture some seroconverters. And what happened in this study, people were again randomised to begin immediate treatment or defer. So 150 subjects. This is basically just for me to read. And so the study got underway. People were being recruited, but all studies have a thing called the Data Safety Monitoring Board, and they review the data as it comes in to make sure there's not some terrible side effect or some result which would challenge the whole premise of the study. And basically what happened is the Data Safety Monitoring Board found that people in the observation arm, that is not on treatment, were progressing at such a rate that a significant proportion of them required treatment. And so they felt the study had to be stopped for that reason. I'm just really skating over this study. It's actually much more complicated than I'm trying to get across. You'll have to read it, but I'm trying to give you the take-home messages. And some of the conclusions are that even if you're infected during the first 6 months, if you've been infected up to 6 months ago and you decide to delay, according to the findings of this study, you're probably going to need to take treatment anyway within the next 18 months. So the authors and indeed the editorial commentators suggest that that in the initial engagement with the patient after diagnosis, the discussion should then very much be on planning, actively planning for treatment as part of their care plan very early on. It's an important, so this study is really an important piece of evidence to add to the when to start discussion that people with HIV need to have with their doctors. And I think, the advice given to many people, as you all well know, would be, well, you can probably wait a number of years, we'll talk about it in a year or so, unless the patient's very gung-ho about going on treatment, treatment would not be offered. So this is suggesting a change in the approach to really raise that conversation about starting treatment early on. And that obviously gives people time to think it through and prepare themselves going on treatment. Okay, the other headline grabber has been the IPREX study, which is in study of antiretrovirals in HIV-negative people with the aim of preventing HIV infection. And I acknowledge that Robert Grant, the principal investigator, gave me these slides and has been out to Australia and always willing to help with any information that we could require back here. Get that one. Anyway, the study design is only amongst men who have sex with men and trans women. Patients were randomised to 2 arms. You take a daily oral dose of PrEP, which was Truvada, a combination of 2 drugs, FTC and tenofovir. So one arm got that, and the other arm got nothing, a placebo tablet. And people were followed very intensively, obviously, to see if there were any seroconversions, any adverse events, whether there were any STIs, how their adherence was, etc., etc. And prevention services were given to all. People were tested monthly, as I mentioned, risk reduction counselling, condoms, 15 or more. I don't know how they arrived at that figure, but clearly it's magic in some way. People were screened for STI symptoms every month. Their partners were also screened. People were given PEP if they were recently exposed, and everyone was given a vaccination against hepatitis B. This is a very big study, 11 sites, 2,500 people. They were all enrolled by the end of December 2009. And as you can see, mainly South America, Sub-Saharan Africa, South Africa, and some Asian sites as well. And the results of the study, again, are pretty clear-cut. There were 35 new infections averted. In the placebo arm, we had 83. In the randomised to treatment arm, we had 48. That's a 35 difference. So 42%, 35 infections averted in the study, which is pretty impressive. But I have to say, I thought, not so great, not good enough when I first saw it. However, this is the data that I find compelling and which Bob Grant presented out here in Australia, and it's not fully written up yet. When you look at the US sites, which is Boston and San Francisco, cities that are very comparable to Australia in terms of gay communities in the major capital cities, it's pretty clear. There are no infections at all in the 2 US sites. For those on PrEP, for those who were in the observed arm, there were 6 in the safety study and 3 in the full study. So that is a much higher result and very, very impressive, I think. So why were they so impressive? Well, they did actually test the blood of all participants to see how much drug they had in the body. And obviously one of the reasons why San Francisco and probably Boston as well did much better than the other sites is that all the people, 95% or almost all, had treatment in their blood, so they were taking the drugs. And there were absolutely no infections recorded amongst those who had detectable drug in the US cohort. Now, people were always concerned that if we have PrEP, condom use will go out the window. This slide shows that condom use remained steady. Whether that continues, we have to see, and the study is ongoing and we'll get more information about condom use. But at this point, after 156 weeks, condom use is steady. Sorry, I'm just trying to find